substance abuse treatment on loss and grieving. Also psychopharmacology, child-adolescent development, violence and youth, anger management, team building, and stress, burnout, transition, and lifespan disorders such as attention deficit hyperactive disorder, mood disorders, and schizophrenia. Dan has also co-facilitated a group for non-offending caregivers of children who have been sexually abused. And for 14 years, Dan was the FASD specialist for the Substance Abuse and Mental Health Services Administration, the FASD Center for Excellence in the U.S. He currently works as a consultant providing training and technical assistance to agencies, community, states, grants and programs, and provinces. Dan has a keen interest in improving outcomes for individuals, families, and the providers and services that support them. Our other speaker will be Dr. Renee Turchi. So just a little bit about Dr. Turchi. After completing undergraduate work at Cornell University and medical school at the Medical College of Pennsylvania, Renee completed residency and chief residency at St. Christopher's Hospital for Children in Philadelphia. Subsequently, she's attended the Robert Wood Johnson Clinical Scholars Program at Johns Hopkins, where she received her master's in public health. Her research and clinical work focuses on children and youth with special health care needs. Renee is also faculty and an associate professor at the Drexel University School of Public Health and the Drexel University College of Medicine. In addition, she's the medical director of the Pennsylvania Medical Home Program and Transition Program, which is a statewide quality improvement program for pediatric practices across Pennsylvania, which is funded by the Pennsylvania Department of Health and the Maternal Child Health Bureau. Renee is medical director of special programs at St. Chris, where she oversees grants and program development and practices. Her research and clinical work around care coordination in children and youth with special health care needs have been presented and published in multiple national forums. So with that, Dan, you can go ahead.
Okay, thank you very much. Thank you all for being here today. I'm really excited to be able to present this because I think medical home is such an essential component for addressing both the prevention and treatment of fetal alcohol spectrum disorders. So you have on the next slide, our contact information for both Renee and for myself. And when you get this, you can feel free, I know, to contact me if you have any questions or I can be helpful in any way after today. I just wanted to very briefly talk a little bit about the fact that, especially coming from a behavioral health background, that up until the DSM, Diagnostic and Statistical Manual for Mental Disorders, was released in 2014, there was nothing about the effects of prenatal exposure. And unfortunately, when it comes to psychiatry, if it's not in the DSM, it doesn't exist. Yet we know that people with a fetal alcohol spectrum disorder have lots of mental health issues that need to be addressed. And as you see that in the approach needs to be different if they have an FASD. So in the DSM-5, we finally have something with a code, and of course the 315.8 was the DSM-5 code, and the F88 is the ICD-10-CM code. So we have a code for dealing with the effects of prenatal exposure and beginning to recognize it. And I think recognizing both the physical and behavioral health issues. And it's, again, one of the reasons that medical home is so important is that although fetal alcohol spectrum disorders are not genetically transmitted, we know that there's multi-generational FASD, so that medically recognizing this in young children is really essential, but also recognizing it in caregivers, because then the way you all deal with caregivers has to be modified. And then in the ICD-10-CM, which of course all of you know is the way to bill and get reimbursement, there are a number of codes that address the issues around prenatal exposure. So it's really important to recognize that for a long time this has been seen as a medical disorder, and now we're seeing it kind of more across the board with both the DSM and the ICD. Um, in terms of prevention, it is one of the very few birth defects that's 100% preventable. So if no woman consumed alcohol during her entire pregnancy, then no child would be born with a fetal alcohol spectrum disorder the way we've defined it now. Um, there are still physicians telling women it's okay to drink as long as you don't drink in the first trimester. It's okay to have a few drinks once in a while you're pregnant. It's okay to drink wine because red wine promotes health for women. Um, but what we used to say at the FASD Center for Excellence is that the only proven safe amount of alcohol to use during pregnancy is none. There is no way to predict how much alcohol will cause how much damage for any individual because we know that different people absorb and metabolize alcohol differently. The age of the mother, their nutritional status, how many live births they've had, all of those come into play. Liver function in the mother and liver function in the fetus all come into play in the effects of the alcohol. So again, for one woman, maybe she can have a few drinks during pregnancy and give birth to a healthy baby, and another woman can have the same amount of alcohol during pregnancy at the same time and give birth to a child with some disabilities. And our view really is it worth the risk? Um, and the IOM, Institute of Medicine, in 1996 came out with a volume on fetal alcohol syndrome and said their conclusion was that of all the drugs of abuse, alcohol by far causes the most serious neurobehavioral, lifelong neurobehavioral effects, more than crack, cocaine, heroin, marijuana. Um, One of the reasons this is really pretty common, much more common than most people recognize, is again because most women don't recognize their pregnancy very early on. The effects of alcohol begin about 2 weeks after conception, continue all the way through pregnancy because alcohol, more than other drugs of abuse, um, it does attack the limbs, the heart, the liver, the kidneys, but exquisitely targets the developing brain. And because the brain is developing rapidly all the way through pregnancy, alcohol at any time during pregnancy can cause damage. The other thing that's really important to convey is that at any point during pregnancy, if a woman stops drinking, it's going to be beneficial. And conveying that, if you come across women who have been drinking during pregnancy, it's still beneficial to stop at any point during pregnancy. Um, and still in our country, about 50% of pregnancies are unplanned. Um, and, some people have thought that this is a poor minority problem. FASD occurs in any community where women drink. And in middle and upper class communities, what I have found is that many times those children born with an FASD are diagnosed with autism, what used to be Asperger's now is high functioning autism, ADHD, or maybe oppositional defiant disorder, because physicians are reluctant to talk with women about their alcohol use. Um, it also does not only occur in women who have alcoholism, it occurs in women who are social drinkers, who may not drink at all during the week, but on the weekend they kick back, they go to the bar, they have a couple of Long Island iced teas, maybe they go to a party and have a couple of appletinis or chocolatinis, don't drink at all during the week. They don't have an alcohol problem, but if they are pregnant, that can cause damage to the fetus. And men are not off the hook. This is an issue for everybody for a number of reasons. One is it is very difficult for a woman to not drink during her pregnancy if her partner is drinking. Partners need to be brought on board in terms of supporting women in not drinking at all during pregnancy. Modeling is really good by not drinking. The other thing is that there is some early research that's showing that men drinking before conception can cause fetal malformations. If a man drinks before conception but a woman doesn't drink at all during her entire pregnancy, the way we've defined it now, a child would still not be born with an FASD but may have other issues. And this is just a chart that Kathy Sulik, who's been doing a lot of research in basic science research in FASD for years at the University of North Carolina, developed, which really demonstrates very clearly, as you see on this chart, that day one of after fertilization, the day one of development is about 2 weeks after conception, long after the last normal menstrual period, long before that's fertilization. Sorry, long before women know that they are pregnant. If you look at the first missed period, which is around 28 days, we already see a forming embryo. So clearly, long before women may know that they're pregnant, this embryo is developing, the neural tube is developing, central nervous system, and really the alcohol can have dramatic effects. And if we go all the way down to day 42 here, that's only the second missed period. And especially for teenagers, they tend to recognize their pregnancies later than adults do, and also tend to drink more in early pregnancy and binge drink more than adults do. So all the way, the second missed period where maybe the thinking is maybe I'm pregnant, um, you already have a well-formed embryo where damage could already have been caused, occurred. So this is not a matter of purposeful, willful behavior to harm a child. This is, and we have to break through that stigma, which is still there. In 40 years, I have never met a woman who said the reason she drank during pregnancy was because she wanted to give birth to a child with fetal alcohol syndrome. But we still have that stigma we have to break through. This occurs a lot where women don't know that they're pregnant, as well as women who do use alcohol and can't stop on their own. This is just a slide that shows that, sorry, any beverage that includes alcohol can cause damage. It doesn't matter if it's beer or wine spritzers or wine coolers or hard liquor. It can all cause damage to the fetus. And Kaskoudas and Graves' research I thought was really interesting, that they did a study with 321 women who were pregnant. These are not women with alcoholism. And showed them different sizes of drinks. And what these women thought was one standard drink of hard liquor was actually 6 standard drinks. And we know that 4 standard drinks within a 2-hour period is a binge. And even one binge during pregnancy can cause damage. In terms of the prevalence, the latest studies in the US are showing that the prevalence of FASD could be as high as 2 to 5% of the population. This is by studying and examining first graders in various school districts. And if it is that in the overall population, 1 in 50 to 1 in 20 individuals, it's much higher in our systems of care. And again, the vast majority of these individuals are undiagnosed because our diagnostic capacity around the country is minuscule. Renee has one of the only FASD diagnostic clinic that I know of in the state of Pennsylvania. There aren't a whole lot around the country. So if we look at that possible prevalence, the number who are actually diagnosed is so small. In terms of the role of pediatricians, again, you see this here. Pediatricians see people regularly. You can pick up issues in the family that others haven't seen because you're seeing people over and over again. You need to begin to think about if a family's having issues. One of the I remember doing a training for sorry. for people who were pediatricians, and I said, don't just think about identifying this in the kids, but think about the family member who brings their child in because they have a high fever, and you treat them, and then you say, okay, if the fever is 100, this is what you do. If it's 101, this is what you do. If it goes to 102, this is what you do. If it's 104, you bring them to the hospital. And then the next day or 2 days later, you get a call from the caregiver saying, my child has a fever of 101, what do I do? Because you've given them multiple instructions verbally, and they walk out and they have no idea what to do next if they may themselves have an FASD. So you may be the first one to pick that up in the family as well as in the child, and that's really, really important. It's really key. And nobody else may be asking about alcohol use. You may be, and the importance is asking about alcohol use at every appointment, not just singling out certain people. It should be part of the routine, because it's not, oh, I think this person may have an alcohol problem, I'm going to ask them. We have to ask everybody. We just have to make it part of, the routine screening, the routine information that we gather. And again, you may be able to then, if it's a woman who is of childbearing age, she may have other children. It's really important to talk about prevention even before women know that they're pregnant. And also, if you begin to recognize it in a child, we know that the earlier this is identified, the better the long-term outcomes. And then can also work with caregivers about how to support this child. Renee, I'm going to turn this over to you.
Great. Thank you, Dan. So we wanted to kind of delve into a little bit the role of the medical home, knowing that all of you on the line here are folks who are providing medical homes across Pennsylvania in some of the highest quality forums out there. And I think Dan touched on so many issues of ways we need to be thinking about this. And I was, really have given this some thought, and I know a lot of you attended our FASD conference. And so wanted to kind of underscore, what is our role of the medical home and us as pediatricians? And how do we think about this? Because, as I said to Dan and others, I'm incredibly sensitive as a practicing pediatrician that we're asked, to do more and more in less time, and we're certainly not often reimbursed for so much of what we do, and we're certainly not at the high pay scale of physicians. So, extending visits and things like that is often not an option, but I think when I think about the medical home and I think about how our practice has evolved with FASD and what we've done, you don't need to have a diagnostic center for sure. A lot of this, as Dan said, is screening, and one of our late slides is kind of just thinking a little bit about an algorithm. So I really wanted my role here to be sort of some of the practical. We all do developmental screening. We use different tools. So thinking about, as Dan talked about, universal screening, I think about it as universal precautions, using that developmental screening. As Dan says, you need to continue to ask about alcohol. I think about it very similarly to domestic violence. When I think about the first time I meet a family, you're meeting a new patient. Often if you're screening at that prenatal or first newborn visit, sometimes it might be a sibling, so you know the family, but many times it's not. So when you really think about practically, right, you're sitting there with someone who you're just meeting for the first time. Trust takes a while to build. It's not often that people are going to admit the use of alcohol or drugs. I've had plenty of times where I've been, looking at a newborn discharge summary or NICU discharge summary where it says clearly there's a urine drug screen that's positive, and when I ask the parent about alcohol or drug use, they deny it, and then eventually it comes up later. So I think I can't underscore the point enough, as what Dan said, to continue to re-screen throughout the child's trajectory and think about that developmental screening. So when you have that close monitoring and you have a child who has some developmental delays, I'm not at all implying that all those children might have been exposed to alcohol, but it's important to think about this. And I think a lot of what we have on the slide here are things that we all do in the medical home. So that patient and family-centered care, building that trust. Thinking about care coordination with these children that have an FASD, as Dan's going to talk about, they often need multiple services. Mental health goes without saying. They often have educational challenges, which Dan will highlight, and many times find themselves in social situations that can be quagmires that require coordination. I'm going to talk at the end a little bit about the algorithm that the National AAP, American Academy of Pediatrics, has developed on helping us all think through when you do suspect the diagnosis, who to send out to, and how to get that, how to get that diagnosis that you can best serve this family. Documenting when you screen, and documenting just in general the struggles that the family has. A lot of you are already doing care plans and care integration, so this isn't necessarily doing anything different. It's just looking through a lens where you're more sensitive that this might be an issue. And helping families think about scientific, the other reference materials. In our diagnostic center, I see lots of reports. A lot of times, families that have these diagnoses, I call it the onion. They've often sought the opinions of many medical providers. And our diagnostic program, they often come with layers and layers of diagnoses and charts. And so sometimes families are often very confused. Even in general, I think we see this in pediatrics where diagnoses and things are thrown out to families. And so what does some of this mean? I think, Dan, I think you might take over here in terms of the outcomes and recognition.
Okay, thanks, Renee.
Sure.
So again, if we recognize FASD in an individual, whether it's a child or a family member, then we see the person as having a disability because their behaviors look like they are willful behaviors, like that family member I spoke about who doesn't seem to get what they need to do when their child is sick, even after you've told them that it really is not just they don't care. It's not a lack of caring. It's not neglect. It really, in these cases, is that we haven't recognized the difficulty in verbal receptive language processing, which we see across the IQ span in FASD. So it can reduce some of our frustration with people, and then we can begin to modify our approach. We need to write everything down. We need to repeat it often because immediate working memory is impaired. We need to get it into long-term memory. And maybe begin to question some of the diagnoses the child has gotten over the years, like ADHD, reactive attachment disorder, oppositional defiant disorder, and say, is that really what's going on, or is this something else happening here? And then if we don't recognize it in the caregiver, we see them as being uncaring, neglectful. We may want to call child welfare, CPS, and maybe the child is taken away from them, and nobody has recognized the FASD, because people with an FASD can be wonderful parents with the right support. But it's with the right support that's really key. So we really want to recognize it again in both caregivers and children. This is a lifelong disorder. It doesn't go away at 18 or 25 or 55 years old because the damage to the brain is permanent damage. However, with the right approaches and the right supports, people with an FASD can be very successful. And as I said earlier, the earlier we recognize it, the better the long-term outcomes. However, I've really struggled over the years with why are we so reluctant to recognize the impact of FASD, and I really do think that part of it is this, that it challenges the basic tenets of everything we've been taught, which is that people learn by experiencing the consequences of their actions and need to take responsibility for their actions. And although that might work for some people, that doesn't work for most people with an FASD. We also think that if we do something for somebody, then we're just enabling them and supporting dependency, and that's a bad thing. And for those with an FASD, no, that's a good thing. That helps them be successful. Also, recognizing FASD, again, challenges our biases and our values about drinking during pregnancy, that women do this on purpose and they're bad people. We need to break through that. And it may bring up issues in our own lives. I do a lot of training for professionals, and almost always there's at least one or two or maybe more people in the audience who come up or speak or come up afterwards and talk about the fact that either they feel that they may have an FASD because this is a spectrum, and some of the difficulties may be minor, and they may be severe, and they've struggled with one or two issues in their life, or maybe that their children may be affected. And I've had several incidents where that's occurred. So maybe we don't want to deal with it, and we don't want to think about it. And then it means we need to do something different, which is harder than doing the same thing all the time with everybody. And for talking with families about recognizing their child may have an FASD, and often what I hear from families is, I can't treat him differently than I treat my other children, because that wouldn't be fair. And we think that fair and equal are interchangeable terms, but as you see in this graphic, on the left-hand side is being equal, treating everybody the same. So all three kids want to watch the game. Baseball game, they all get the same size box to stand on. That's being equal, but unfortunately only the two taller kids can watch the game. But being fair means that everybody gets to watch the game with what they need. So that's what we really need to try to do. We want to be fair, not equal. We can't treat everybody the same, but it's easier to do the same thing with everybody. Especially helping families, caregivers understand that they can't treat all their children the same if all their children have different needs. And again, the concept of using natural consequences puts people at risk. We see lots of families who are repeatedly homeless, who have an unrecognized FASD, because we say, well, you have housing. If you don't pay your rent, you'll get evicted. Then you will learn to pay your rent. May work with some people, doesn't work with those with an FASD, puts them at risk of being homeless. So you may see people who are repeatedly homeless, who are repeatedly on the brink of getting evicted. And maybe it has to do with difficulty in managing money, which is an abstract concept. And again, as I said, we need to provide support for people so that they can be successful, and doing things for or with them, taking them to an appointment, working with them on how are they going to get there, reminding them about the appointment, maybe sending a text, and being able to say to them, I don't say things like, I know that you have trouble remembering things, but I say things like, there is so much going on in your life. I know it's hard to remember everything you need to do. Would it be helpful if we send a reminder the day before your appointment, of your appointment the next day, and then a reminder that morning of like when you need to leave to get to your appointment on time? This is for somebody who's constantly missing their appointments or coming late for their appointments. It might not just be an issue of not caring. It might be an issue with the sense of time, which is an abstract concept which is also often impaired in FASD. Now we know that not everybody prenatal exposed to alcohol has an FASD. We can't predict who will and who won't. But we know that across the spectrum, from mild to severe, when there's an FASD, we see brain damage. And the brain damage, the experts in brain research and FASD have said that the behaviors we typically see are due to the damage in the brain and how the brain is processing information rather than willful, purposeful behaviors. So this study, these two studies that I have here, I think are just really important. This is a study that was done by Susan Astley at the University of Washington that used magnetic resonance imaging, magnetic resonance spectroscopy, and functional MRI to examine the brains of individuals with an FASD and a control group, giving them different tasks to do. And what Susan found is that those with an FASD did really poorly on this task. It's called the two-back test, where they flash a group of pictures and they say, when the picture you're seeing is the one you saw two before, you press this button. And in that task, she found that the dorsolateral prefrontal cortex of the brain wasn't working well enough. It was hypoactive, and that's an area of the brain that's a measure for working memory. And working memory is what we rely on when we tell somebody to do something. So if you are telling one of your patients, you need to do X, Y, and Z with your child, you're relying on their working memory to be able to do that. If a parent tells a child, go upstairs, brush your teeth, get in your pajamas, get ready for bed, they're relying on their working memory. And if their working memory is impaired, and this is across the IQ span, because we've identified people with an IQ over 140, genius level, who still can't follow 3 directions at once because working memory is impaired, it looks like they are oppositional. And this is why they often get a diagnosis of oppositional defiant disorder, which is frequently a misdiagnosis. So the idea of recognizing this is everything needs to be broken down to one step, one direction, one rule at a time, with lots and lots and lots and lots of repetition and consistency to get it past damaged working memory into long-term memory, which is less impaired. And then these studies are done. Joanne Weinberg at the University of British Columbia did some of these early studies, and then others have picked up with them. And what Joanne found, and this is basic science mouse research, is that the mice prenatally exposed to alcohol under minor stressful situations had an over-release of cortisol. And the implication for that is that we see individuals with an FASD who we say overreact to minor situations. Somebody bumps into them, they haul off and punch them in school, and they get into serious trouble. Somebody takes their pen or pencil and they melt down. There's a change in the time they have dinner at home or bedtime, and they freak out. And we say you're just overreacting, and we consequence them for that behavior. But recognizing that it's not just overreacting, it's a physiological body response of an over-release of cortisol. So Joanne is working on how do we get the hypothalamic pituitary adrenal axis back down to normal levels and not so hyperactive, hyperexcited. But also it means that we need to work on recognizing when those with an FASD begin to get stressed or anxious. What I hear from families over and over again is, my child goes from 0 to 1,000 in about 30 seconds. And that's that over-release of cortisol, which we need to try to interrupt. So here are some behaviors that we typically see. I know we don't have too many minutes because we want to leave time for some questions. And I want Renee to get to the importance of the algorithm. So you see these. So these are individuals who tend to be very friendly. They're talking all the time, so they come across as much more intact than they really are. Kids and adolescents and adults are at high risk for abuse and trauma because they don't recognize dangerous people in dangerous situations. As young kids, they are very difficult to parent. They don't eat well, they don't sleep well, they may have poor sucking reflex, they may be seen as very picky eaters, but it has to do with temperatures, textures, tastes of food. Some of them don't develop good enamel on their teeth. And then as older kids, adolescents, and adults, they don't recognize danger. So they put themselves in dangerous situations over and over again. And they're very literal in their thinking, so be careful how you say things to them because they will take things word for word. And again, if you're literal, that area of the brain in the frontal lobes responsible for abstract thinking is damaged, then you don't get a sense of time, and that's why they're often really late, but they leave for their appointment at their appointment time. So you never text them or set in their phone, you set a reminder in their phone for their appointment time, you set a reminder for when they have to leave for their appointment. So these are some difficulties if somebody is very literal in their thinking. And as I said earlier, one of the problems in FASD is that their verbal receptive language is much more impaired than their expressive language. So you're giving a caregiver a whole list of instructions and you're saying, do you understand what I'm asking you to do? Uh-huh. Do you have any questions? Nope. You need to check true understanding. You know, can you tell me what it was that I just said? Because sometimes I'm not as clear as I want to be. I want to be sure I was really clear. And then talk about how can I help you remember that when you need it because there's so much going on in your life. But because they can talk better than they can take in, and again, it's especially verbal, so we need to use more senses, visual, tactile, whatever we can. They come across as much more intact than they really are. And everything we do relies on verbal receptive language processing. Think about how much we talk to people. And even if we hand them a piece of paper with things written down, unless we go over it with them and have somebody else go over it with them and touch base with them, they really don't get it. I put these couple of slides in here. People with an FASD are at high risk for sexually transmitted infections. It's an area we don't talk a lot about, but we need to talk more about. And they're also at high risk of suicide for a number of different reasons. And especially if you're working with children and adolescents, be really aware of the risk for suicide, especially if there have been other suicides or other deaths. And we don't like to talk about death, so we use nice words like he's with God or she's at peace, and then this person wants to be at peace or with God. So they say, well, if I kill myself, then I'll be at peace or I'll be with God. Or they see other people being upset and they say, well, then if I kill myself, I'll see that people care about me because they'll all be upset. But they don't think through to they won't be here to see that. So we need to recognize the risks of sexually transmitted infections and the risk of suicide in the youth that you come into contact with, and also in families when maybe they've had some of their children taken away from them. And women especially, we have to give them a positive reason for living. There are very specific things that we can do in modifying their approaches, like reducing the stimuli in their environment, using softer lighting and colors. Those things are really important. Being very consistent in routines, bedtime the same time, and this is what I tell parents all the time of kids with an FASD. Bedtime the same time every night. Don't have a different bedtime on weekends and weekdays and holidays and vacations and school days and not school days. Because then they will never know when to get to bed and you'll always be fighting about it. And be very specific and concrete about what does it's bedtime. And prepare them early and often. Don't spring anything on them, because springing something on them increases anxiety and stress and the release of cortisol. So in 15 minutes, it's time to get ready for bed. And what you've gone over with them is what getting ready for bed means. It means having your teeth brushed in your pajamas in bed, or whatever it does mean. We need to be very specific. Meal times as much as possible, same time every day. And when there's a change, prepare them with that early and often. Again, I said don't take missed appointments as not caring. Think about what's going on and why they're missing the appointments. And then you see there's a whole list here. And again, I think after the presentation, you'll get these slides, so you'll be able to look at that. And it's really good to have them for caregivers who may have an FASD. Have them carry a notebook where you as the provider writes down what they need to do, writes down their appointments, writes down their medications. Not they're expected to write them down, but you need to write them in that notebook. Very, very important. We want to use person-first language, so nobody is FASD, but it may be a person with an FASD. Nobody is a substance-using woman, but maybe a woman with a substance use disorder. And person-first language is really important because language influences our attitudes, our beliefs, and our behaviors. And nobody is their illness, whatever their illness is. And I've talked with friends of mine who have diabetes, and for years they say, I'm a diabetic. And it's like, is that who they are? Or are they a person with strengths and abilities who has a disease called diabetes? And it really makes a difference in how we look at the person. So if we recognize an FASD, then we don't rely on the verbal. We use more senses. We do a lot of repetition. We think about the words we say, how they could be misinterpreted if somebody's really literal in their thinking. And we break things down to one step at a time and always check for true understanding. What does that mean? How would you do that? How can I help you do that? They often do great with a mentor, a positive buddy for the child or for the caregiver. So, that might be an important thing as well. And really key is recognizing that those with an FA, that we can have a huge, you can all have a huge impact in people's lives by beginning to recognize this. Renee, I want to turn this over to you now.
Great. So I'm going to go pretty quickly through these last couple slides because I want to give people a chance to answer questions. But I think I highlighted some of this earlier, that like linkages to our services and community resources, thinking about early intervention in school. There's actually going to be a policy statement coming out from AAP in pediatrics in about 6 months, looking at these very issues, medical home and FASD. And in that, we talk a lot about thinking about things like the IEP and the education system, very specifically for this population. Also thinking about a lot of what you guys already do with parents and families, and recognize that for fetal alcohol spectrum disorders, there is an organization called NOFAST, the National Organization on Fetal Alcohol Syndrome. So again, it's performing and embracing family-centered care and recognizing that in this case, you often are going to have families dealing with addiction, adoption, and transition. So a lot of the social things that many of us are dealing with, but again, with the lens of alcohol. This is a very busy slide. It's a little Turchi-esque here, but bear with me. I think I showed a lot of this slide to you guys at the conference. I just put this in here to remind me to let you know that there is this algorithm that exists. Because I think in thinking about, we threw a lot of information out at you, and the idea of this algorithm is kind of thinking about in your medical home, as you're, looking at children and families and you're looking at developmental surveillance, kind of walking you through with something that's kind of, you can hang in your workroom or your area to kind of say, what are some of the next steps? And so it's available, obviously, in our slides, but it's on the websites, the National AP FASD website, as well as in several articles. So if you're interested, I think it should be in our learning library. If it's not, we'll get it up there. But the whole idea is that as you screen for developmental disabilities, if you kind of walk through this, yes versus no, and then looking for things, the physical features of what would be fetal alcohol syndrome that we went over in our conference, with some of the geneticists and folks, and then if there's not, again, it doesn't mean that the child's not on the spectrum, but kind of thinking about this DSM criteria and the fetal alcohol effects, and it kind of walks you through how to think about this in the medical home, and thinking about the partners that we need to work with these families, when to think about referring to genetics, when do you need speech, physical therapy, occupational therapy, when might a neuropsychological evaluation be important. So that's kind of, again, it's hard to read on the slide, but when you see it on an 8.5 by 11, it's worth printing in color and having out there if it's something you're thinking about. A work group worked really hard on having something practical for pediatricians. So with that, I want to open it up for questions. I think we probably only have a couple of minutes. Sweeney, maybe I'll turn it over to you to moderate the questions for us. I have some references here in our slides.
Sure. So one of the questions that came up was, are kids with FASD at risk to develop alcoholism as adults?
Okay, that's a great question.
Dan, you want to take that?
Yeah, sure. That's a great question. And actually, some of the research studies have shown that maybe about 35% of those with an FASD develop alcohol problems. Again, how much of it may be the family history, how much of it may be a genetic loading and a genetic vulnerability. It's probably a combination of those. Some do and some don't, but they are at higher risk, so we have to watch for that. My concern, especially these days, is, of course, with the legalization of marijuana, because I've heard from a number of families their concerns with their kids with an FASD, their adolescents, who are getting involved in smoking pot because if it's legal, it must be okay, just like with alcohol. It's legal, it must be okay, it must be safe, but cause some pretty serious difficulties for somebody with an FASD because, of course, it does affect the brain. So, yes, it's a great question. Yes, they are at higher risk. Exactly how much and exactly why, we don't know. But I've done family genograms for years where we found 5 or 6 generations of, alcohol use in the family, part of the family tradition. So again, I think it's just that combination.
Great, and I just want to remind everyone that if you have a question, if you hit #6, you will unmute yourself, and also you can type a question into the question and answer pod.
Another question. Just while we have everyone on the line, I just wanted to let folks know that what Dan and I were thinking, based on folks' feedback from today's webinar, is that we covered a lot of material today, and so we were thinking about having this be sort of a series of sorts, where we would cover delve more into some of the educational issues and some of the things we talked about in terms of resources. So we welcome feedback on that, but we'd love to see us spend a little more time on this, because we know we sent a lot of information. So love to hear if folks would be interested in hearing more.
That's great. If there's anyone that doesn't have an opportunity to write their questions or they want some more information, you can definitely email me, Iris, at the Academy email address, and then that way we can forward any questions or comments for next steps to Renee and Dan. We're going to ask one more question, and then we'll conclude this webinar.
So another question that came through was, what's sort of the best way to assess parents' drinking habits? So when parents are asked, how often do you drink, if they say socially, that might differ. The definition of social drinking might differ for different parents. So sort of what's the best way to gauge drinking habits among parents?
Dan, I think you'd be better suited to answer that than me.
Okay. Well, one thing I would do is if they do say, well, I just drink socially, can you tell me what that is? Like where do you drink? And when you do drink, how much do you have? Because, and I like to normalize it. In our society, lots of people celebrate different things. People celebrate birthdays, anniversaries, holidays, vacations. And when people celebrate, lots of people do go out and drink, or they drink at home, or they go to a party, and they may have wine, or they may have margaritas, or they may have, martinis or appletinis or Long Island iced teas. So when you do drink, what is it that you do drink, and what do you use to drink? That's really the key, instead of talking about how many standard drinks do you have, because nobody knows what that means. But, I have a 40-ounce Foster's. When I drink a beer. Well, that's important, because that's more than 3 drinks. Or I go to the bar and I have 2 Long Island iced teas. I never have more than that. That's certainly a binge. Or I may have a couple of margaritas. So I would just keep the conversation open, but as in a non-judgmental kind of supportive way. We're not blaming. We're not judging, and the importance of knowing that information, and I will say this to people, the importance of knowing that information is so that we know how to help you and your family best. That's really why I'm asking that. And
yeah,
I think that helps.
One thing I might just add to that, because I think it's an excellent answer. Yeah. In one of the work groups I was on, there was someone who talked about, even in that prenatal visit, one way to even introduce it would say something like, as Dan said, to normalize it. It sort of struck a chord with me, where he talked about saying, what he says to parents is, many women don't find out they're pregnant until, they're 1 or 2 or 3 months pregnant. And as a result, sometimes they may have drank alcohol prior to knowing they were pregnant. Was that your case? Something to that effect. If that's another way to normalize it, and sort of, again, we're not saying that it's okay, but at least gives people the chance, especially if you highly suspect it. That was something that he had said he did in his practice that I thought was an interesting way to approach it.
Oh, thank you, Renee. Yeah, absolutely. And that reminds me, it's also important, if you're trying to evaluate it, in terms of a child maybe being affected, I will always ask, if you can think back to the 3 or 4 months before you became pregnant, how much were you partying? How much were you celebrating? And what did you celebrate with? Because that is early pregnancy for most. Maybe 2 or 3 months. And if it's teenagers, women who are pregnant as teenagers, I might ask in the 5 or 6 months before you became pregnant, because if you ask, when did you become pregnant, a lot of women will talk about when they found out that they were pregnant. That's how they evaluate when they became pregnant. But we want to know, even before they knew they were pregnant. So yeah, Renee, that was a great point to bring up.
Great. So since there's no other questions, we're going to wrap up. Thank you to Dan and to Dr. Turchi, and thank you all for being on the webinar today. If you have any additional questions, feel free to email Iris. Thank you.
Thank you very much. Thanks for this opportunity. And thank you all for what you do every day.